We're talking today with Dr. Katrina Alford, who is a health economist. She has a paper in our 16th of November issue on health expenditure on Indigenous health. Thank you for your time today.
Thank you.
Now, you've written about closing the gap, and your argument is that although we're spending money on Indigenous health, we're not spending anywhere near enough. Is that a fair assessment?
Yes, both quantum, allocation and distribution and the funding model.
Right. Don't we spend more on Indigenous health per person than we do on non-Indigenous health?
Well, the ratios are about 1.47 Indigenous to 1 Indigenous, and government total is just about 2.
Yes.
But in reality, the health indicators suggest that needs to be weighted upwards considerably,
Right.
to account for disproportionately greater health need. Moreover, the allocation of it is very skewed and flawed.
Okay. In what way is it skewed?
Firstly, nearly half of the expenditure on Indigenous health is on hospitals.
Right.
There is a disproportionately low levels of expenditure on Indigenous primary health care, particularly in the Indigenous specific community control sector, which is a great shame. More than 3/4 of all of the Indigenous health expenditure is on mainstream services,
Right.
rather than Indigenous specific services.
So they're not necessarily culturally appropriate?
For a whole host of reasons, including that, no, they're not appropriate. There are quite substantial barriers to access, which we can discuss
Sure.
in a moment. But the upshot is that there is very substantial underutilisation of mainstream health services by Indigenous Australians across the board,
Sure.
but in some areas in particular. The big health expenditure items, like health is about 10% of total Australian government health budget, so it's a big ticket number. The top 3 items are very little used by Indigenous people, the first being income support for seniors. Well, 2/3 of Indigenous people are dead before the age of 65.
Yeah.
Medicare, Indigenous utilisation is about 0.7 that of non-Indigenous utilisation of MBS items. PBS it's lower, medical specialist it's lower again. So there is underutilisation of mainstream medical health services. There should be, but there is not, a redirection of expenditure away from mainstream large mega units, now called primary health network sites, previously Medicare locals, towards the community controlled sector. There is not. There is also a geographic imbalance in the allocation of funds, in as much as Aboriginal people in capital cities and metropolitan areas are very poorly served in terms of Indigenous specific health expenditure. There are very few Indigenous specific primary health care centres in metropolitan Australia.
Yeah.
Proportionately more in remote areas of Australia. I don't wish to pit urban Aborigines with remote area Aborigines, but the reality is that Aboriginal people living in urban Australia are quite wrongly assumed to be able, ready and willing to access mainstream health services, primary health services.
Yeah.
Many do not, with fairly disastrous consequences for Indigenous health.
Do you think the will is there?
I'll leave that to the politicians to debate, but I am very concerned about the disconnect between what is said on the one hand by way of rhetoric and policy pronouncements and commensurate funding and resourcing on the other. I note that recent government policies will aggravate the situation. We could cite very many, one of which is Commonwealth health payments to the states and territories have dramatically declined. That will impact on Indigenous people's access to hospital services. The rates of hospital usage with procedures among Aboriginal people is rather low.
Yeah.
They discharge themselves against medical advice 8 times higher. elective waiting times for everybody are already long, are likely to be longer. That's one policy with ill effects. The encouragement of private health insurance, including by way of fairly massive fiscal subsidies, is another policy which is directly and negatively impacts on Indigenous health finance, in as much as it's a very substantial, in fact it's one of the top 20 health expenditure items by the Australian government. Well over half of the Australian population has health insurance.
Yep. By
and large tend to be more well-off people. And by contrast, at max, about 17% of Indigenous people have health insurance. So if you put together the large subsidies for the big ticket items, income support for seniors, which Aboriginal people don't access for the worst possible reasons, the Medicare financing, which Aboriginal people underutilise, the private health insurance, they're all areas of expenditure, some part of which could have gone to Aboriginal people and has not. They're policies which have a negative impact on Aboriginal health.
Right.
The pie is large, the pie is growing, the Indigenous proportion is shrinking, arising from the impact of these various policies.
If you were Queen for a day, what would be the first thing you'd do?
There's a range of things I'd do. I would like to be in the boiler room pressing the buttons at this point in time, rather than
which ones would you push?
Speaking in a podcast. First of all, I'd guarantee funding security for primary health services, Indigenous specific ones. I would quarantine those services from budget cuts.
Yep.
For the foreseeable future, for the next generation at least. I would undertake fairly massive revisions to the health funding formula and administration to address fairly substantial system failure in relation to Indigenous health funding. I would, in relation to Indigenous primary health funding, I would first of all index it so that the real value of it's maintained over time. I would weight it by a factor of at least 2, possibly substantially more, to reflect disproportionately greater health need. I would address the geographical inequities in as much as Aboriginal people in urban areas are very poorly served in terms of Indigenous specific primary health centres. I would directly address the issue of cultural competence in mainstream health services. Much is said, little is done. It's no good putting up a couple of stickers in waiting rooms and talking the talk. Cultural competence deficiencies have been identified in most mainstream health services, in the National Aboriginal and Torres Strait Islander health reports. I would not assume that urban Aboriginal people can and should make do with mainstream services. They have a right to Indigenous specific health services, as is recognised in remote areas of Australia. In fact, there appears to be a bit of implicit racism in health funding, in as much as the health funding is disproportionately weighted towards remote areas, which is not to suggest that it's not needed, but it does suggest that there appears to be an assumption that real Aborigines live in remote areas. I would redirect a considerable portion of mainstream health expenditure, in particular away from Indigenous earmarked funds for the primary health networks and Medicare locals, and from divisions of general practice to a lesser extent. I would attend immediately to the Indigenous health workforce issue. It is very rare to see an Indigenous person other than the token Indigenous liaison officer you find in hospitals, in general practices and in health organisations. Indigenous people are 3% of the population, but they comprise about 0.4 or 0.5% of the Indigenous health workforce, and abysmally low proportions of Indigenous doctors, doctors are Indigenous, and nurses, who are also less than 1% of the nursing workforce. I would also make quite sure that an accounting framework, a reporting framework, an evaluation framework was in place that included targets. I would make sure that those targets were SMART. The terminology these days is specific, measurable, achievable, time-bound and realistic. We also have to address the social determinants of health, income, employment, education and housing, all of which are ongoing massive concerns. I note that up to a half of health outcomes may be attributable to those social determinants of health, but that should not leave unscathed or unattended the health system. Within the health system, there is a dire need for reform to improve outcomes. For example, over half of all Aboriginal deaths in Australia arise from inadequacies in primary prevention. So that is within the scope of the health system, and it's amenable to reform with appropriate resourcing and appropriate policies. I've been quite shocked by my findings. I'm hoping that others will pick up the baton and carry it. I'm pleased that I did it, but they are fairly shocking findings.
Yes. Well, hopefully we can get them out there and get something happening, hopefully.
Yes.
Thank you for your time.
Thank you, Kate.